By the early 80s, we began to see a period where, OK, you'd had some immunisation against certain diseases, often delivered in these rather campaign-like forms. So a big government force and military force would be acting on a particular disease and rolling out a vaccination programme. But this was obviously quite patchy in terms of where it worked and how much effect it had. So by the early 80s, immunisation coverage was very, very patchy around its diseases and around the places where it had been effective. And this was the time when the World Health Organization kind of took things in hand and launched what became known as the EPI, the Expanded Programme on Immunisation, which was an attempt to try and get universally the whole of the world's population in infancy immunised against a series of basic diseases. And those that were part of the package at that point were measles and polio, which we've talked about, and a range of others, diphtheria and tetanus and pertussis, which is whooping cough, which were combined in the DTP vaccine, and also BCG against tuberculosis. And so there was a kind of standard set of antigens, but also the other big change was the attempt to make vaccination a routine part of primary health care and to integrate it with what was just coming into play as global primary healthcare systems. So this was also the kind of period of Alma-Ata and primary health for all, and the attempts across the world with varying degrees of effectiveness to set up primary healthcare systems and often tiered health system approaches which had hospitals and then secondary referral centres, but at the base often rural clinics and health centres. The attempt was to integrate vaccination as something routine which would be part of primary healthcare programmes, and particularly mother and child healthcare and the kinds of infant welfare clinics and MCH programmes which were supposed to be delivered at the lowest tier of the health service in many countries. So this was the attempt, and then there was also this kind of mode of delivery, the sort of National Vaccination Day, which were then and is still to the present used as a way, still taking that kind of campaign form to catch up, or in an instance of an epidemic, or twice a year these big posters to encourage everybody to bring their child forward for measles or polio vaccination. So these things happened across the world, and of course they went along with both some rather different images. So now we're seeing not a military campaign, but a kind of connection between responsible parenthood and happiness and health for children. So there's a very different image here. We haven't got the miserable polio-stricken child. We've got the idea of the happy, playing, smiling baby, happy, healthy, because immunised. And also a kind of strong impetus to parents, particularly mothers, I mean a strong gender emphasis here, on bringing a child for vaccination as part of being a responsible mother and a responsible parent. What also went along with these ideas of responsibility were forms of education. And so we see in the posters of this period more information about what the different vaccines are, the dates, the numbers of months, 2 and 4 and 6 months at which you should be bringing your child for each of those programmes. And this poster information about information, education and communication would also go along with sort of talks and education programmes at these infant welfare clinics. So some changes in image and some kind of expectations of vaccination almost becoming a social expectation, a social responsibility, part of being a good parent, with different images, of course, as to the parent who perhaps doesn't take their child, and we'll come on to thinking about that in a little while. The late 1980s was when the measles, mumps and rubella vaccine was introduced. This was rolled out initially in European countries and in America, and still in many developing countries it's not used. It's often still an individual measles immunisation that's given. That's not to do with controversy. It's more to do with where mumps is a problem and where rubella is a problem. But what's interesting from this period again is that there's another sort of imagery which emerges in these ideas of umbrellas and of rainbows. There's this sense almost of an encompassing notion of protection. That is this vaccine in a way a shield? Is it a way of shielding a child and a body and a community from things that might come to it? This is quite an interesting image, given some of the broader cultural shifts in understandings of immunity that were going on at this time. Now, for those of you who get interested in this, there's a rather wonderful book that I think I put on the reading list by Emily Martin called Flexible Bodies. It would be geared towards those of you who are kind of into medical anthropology a little bit, because what she does is to argue that over the period from the 1950s, so that was the early polio days, there was certainly in Euro-American societies, there was a major shift in how immunity was thought about. At the time, the sort sort of dominant cultural view, and indeed the view in science, sort of permeating into popular culture, was that germs entered bodies through exteriors. And that was what went along with the vulnerability of the skin, with the need to wash a lot, with the way to protect yourself was to be clean, to, as it were, keep your body and keep your skin as a surface that protected you from germs that would come from outside. But over the sort of subsequent decades, there was a sort of interaction between what was being learnt in science about the operation of the immune system and the functioning of these very specialised cells in the body, which would enable cells to react flexibly to almost anything that came into the body in combinations of different kinds of immune system cells. So immunity came to be understood as a bodily system for fighting disease, and also one that was flexibly specialised. So these cells could combine and recombine in different ways. They could pick up on a particular antigen and create a kind of lock-on effect to fight that particular disease. So not that idea that goes with the military metaphors of a body surface that sort of has to resist attack from outside, but an immune system that could fight from within. So these were powerful ideas in science, but what Martin does is to argue that they also fitted with some broader ideas in popular culture. At a time when industry was changing towards thinking about flexible specialisation in production, towards people's ideas of their lifestyles were changing towards much more individualised models of how people engaged in the world and wanted to do things. So it kind of went along with almost neoliberal ideas about the individual body and the ways they operate in the world. And so this notion of immunity and also affected how people thought about vaccinations. Some of that thinking is part of parental thinking even today, that vaccinations act on their individual child's body in a way that might vary according to what that body is like and towards other bodily experiences that might have happened earlier. But this different idea of immunity and protection is to some extent encompassed in these posters. So what did this all add up to? Well, this is a set of figures from a little while ago now, but the situation has not changed unduly. The effects of the first sort of 30 years of that EPI programme, that big global rollout, were quite dramatic. I mean, if this is the early 1980s, what we saw from that period up to 2006 was an enormous growth. I mean, OK, coverage had already been quite high in some industrialised countries and in Europe. But we saw enormous growth across sub-Saharan Africa, across South Asia, across the Pacific, across the Middle East, and indeed a big increase in industrialised countries, to the point where globally average coverage was about 79% in 2006. Some variation, but basically pretty high. OK, so we've got something that looks quite a lot like a success story. But I want for us to think rather harder about this gap, because filling that gap has been a persistent challenge ever since. We've seen almost these curves have flattened out to some degree, and it's proved really, really hard to increase coverage, and yet it's often, for some of these key antigens, particularly for measles, that bit that really matters, because that's what creates herd immunity in a population and is actually important for wiping out a disease so that it no longer transmits. So we'll think a bit more about that gap. What happened around the polio story, which had continued through the EPI programme and also through these kind of polio campaigns? Well, polio also became part of a big eradication initiative which was established in the late 1980s. And by this 2006 point, it had been, at one level, pretty effective. So if this is where polio was endemic and a serious problem in 1988 when the eradication initiative started, by 2006 it had been wiped out in most places. But interestingly, some really important pockets remained. One was Nigeria, and the other was really South Asia, so India and Pakistan. And we'll be thinking about the reasons for that, which are quite complicated and a kind of cultural and political rollout later. But this has gone on being, as it were, frustrating. So whereas in routine vaccination we've got a problem of a 20% gap, with polio there's been the problem that it's actually proved really, really, really hard to get rid of it altogether, and despite enormous international effort. So this has been the challenge over the last 20 years, completing this polio eradication campaign in these outstanding pockets, Nigeria and parts of South Asia. And these are posters which are about vaccinations vaccination days. So these are not about the routine incorporation into primary healthcare. It's about having these big rounds which call people together and put a lot of resources and have vaccinators going out door to door and try and bring people into public places to have their children vaccinated. And also meeting that 20% gap.